Good evening, all. So, our topic is amniocentesis and chorion villus sampling. It is a green top guideline number 8. Generally, from this particular GTG, they are asking one or two SBAs, not a very important from EMQ point of view, but a very simple guideline. We'll be able to finish in 5 to 10 minutes. Additional miscarriage risk, they are asking this miscarriage risk after this invasive procedure. Whether you perform amniocentesis or CVS, for a singleton pregnancy, miscarriage risk is 0.5%, less than 0.5%. Remember, it is less than 0.5%. Okay. Then they are asking about the timing for this invasive procedure. Okay. Amniocentesis not done before 15 weeks of gestation, and CVS is done after 11 weeks of gestation. It is not done before 10 weeks of gestation. They will ask you the timing. So select 11 to 13.6 weeks of gestation. So CVS is never done before 10 weeks of gestation, preferably from 11 weeks to reduce the technical challenges. In twins, additional miscarriage risk following this invasive technique is 1%. So please look in the question what they are asking, whether they are asking the miscarriage risk for the singleton pregnancy or whether it is for the twins. For twins, it is 1%. For singleton pregnancy, it is less than 0.5%. Okay. And when you are dealing with this invasive, always have the screening of the patient for the bloodborne viruses and viral load antigen test before invasive test, and discuss if they are positive. You will always discuss the transmission risk. Okay, generally there is one EMQ also in one of the book regarding this bloodborne virus transmission. Okay, same thing what we have discussed. The timing is mentioned here. For CBS, it is 11 to 13.6 weeks of gestation. However, in certain cases, it may be performed between 14 to 14.6 weeks of gestation. Okay, amnio timing is 15 weeks onwards only. Okay. What are the additional risks? For singleton, miscarriage risk is 0.5%. For CVS, for amnio, same risk. Okay. And if amniotic fluid appears cloudy or purulent, there are clinical features of intraamniotic infection. Then you will send the sample for microbial analysis and you will offer the antibiotic to the patient. This is also a question in one of the book that this procedure is performed and the amniotic fluid is looking cloudy. What will you do? You will send the sample for microbial testing or microbial analysis, and you will offer the antibiotic. That is what is the next step. Okay. Now concentrate on this particular chart. Okay, there are many numbers and pertaining to this amniocentesis and CVS. So what is the chance of second sampling? You have performed the procedure, but it is inadequate or you are not able to get the sample. So you perform the second sampling or repeat the procedure. In both, it is 6%. Okay. So in numericals, they can ask you whether it is amnio or CVS. There is a 6% chance that you may have to repeat the procedure. Now, blood stain sample, it is applicable only for amniocentesis. It is 0.8%. It is not applicable for CVS because blood stain sample will be only in amnio only. It is less than 1%, that is 0.8%. Then confined placental mosaicism, it will be applicable to the CVS only. It is less than 2%. Okay. Then there are maternal cell contamination in the sample is 1 to 2% for amniocentesis. In both, it is 1 to 2%. Rapid test failure is 2% in both cases, and failed cell culture. So you have taken the sample, but the cell culture has failed in 0.5 to 1% in both. Okay. Now, how to remember all this? Actually, you remember just 6% repeat procedure. Blood stain sample will be less than 1%. In amnio only it is applicable. Then these three things you put together. That is, I always remember cell culture fail, CCF. Then you have MCC, maternal cell contamination. Then you have rapid test failure. Okay. So C followed by M followed by R. In the sequence of alphabet, C comes first, then comes M, then comes R. So we begin with 0.5 to 1%, 1 to 2%, and 2%. Okay. CCF that is cell culture failure, 0.5 to 1%, maternal cell contamination 1 to 2%, rapid test failure in 2% of cases. Okay. While rest of the complication, that severe infection, fetal injury, maternal visceral injury, they are rare. Okay. You can remember these particular figures. Okay. Just you have to note it down somewhere and look daily or revise at least weekly these particular charts. Okay. Now, regarding the training, what does the guidelines say? The person should be competent and at least 20 amniocentesis or CVS procedures should be annually done. Okay. Then there should be continuous audit. Okay. With respect to the multiple insertions, failures, bloody taps, procedure related losses, etc. They should be audited. Okay. Then seek support from more experienced operator if anticipated or encounter difficulties. Okay, so these are the things with respect to the audit and maintenance of the standard, how to maintain the standard they have mentioned. Okay, now in this particular slide there are many figures, but don't consider, just remember that early amniocentesis has resulted in 3% requirement for the multiple. So if you carry out too early, then the requirement of the multiple needle insertion, which was, uh, uh, repeat procedure is 3% of multiple needle insertions, and early amniocentesis has cytogenic implications with increased risk of cell culture failure 1.8% compared to 0.2%. So when you do the amniocentesis early, the cell culture can fail. Okay. So what we have seen, cell culture failure was seen in less than 1%, 0.5 to 1%, then 1 to 2% and 2%. That is what we have seen. Okay, cell culture failure was seen in 0.5 to 1%. Then maternal cell contamination was between 1 to 2%. And third, what we have seen is a rapid culture failure, I guess. Okay, rapid test failure. Rapid test failure was seen in 2% of cases. Okay, but that will be increased if you carry out early. Okay, then what is the role of third trimester amniocentesis? The risk associated with the third trimester diagnostic amniocentesis include the risk of preterm labor. They are likely to be low. Okay, the risk associated with the third trimester amniocentesis, including the risk of preterm labor, is low. Okay, women should be informed that there is a higher risk of cell culture failure with amniocentesis performed in the third week, third trimester. Okay, overall risk of is 10%. Just now I mentioned that normally it is cell culture failure is 0.5 to 1%, but if you perform in the third trimester, there's a 10 times. That means 10% risk of culture failure if you do it in the third trimester. Okay, screening results from for the bloodborne viruses, viral load, etc. You have to do before you pose the patient for this invasive test. If they are positive, you have to give the appropriate counseling. And the risk of mother to child transmission of HIV for women on a heart is very, very low. Okay, so if the patient is on heart, you can go ahead with this particular therapy, but you will not carry out the procedure unless the screening is complete. Okay, so ART should be optimized to aim for undetectable viral load prior to the amniocentesis or CVS. Before you go ahead with the amniocentesis, you have to optimize the viral load. Okay, the risk of mother to child transmission of hepatitis B is low with viral load less than 6.9 log 10 copies per ml. Okay, there is no evidence of risk of mother to child transmission of hepatitis C based on limited data. So hepatitis C transmission is not there. Hepatitis B transmission is low if the viral load is less, but it increases with the viral load. And even if you optimize the HIV viral load, then also the risk is very. So this is a very short guideline. In this guideline, what you will remember is the risk of miscarriage in the singleton pregnancy, risk of miscarriage in the twin, then the timing for the CVS, timing for the amniocentesis, and various percentages which I have mentioned. That much is there from the examination point of view. Okay, so that finishes this simple GTG. We'll finish the last one small talk in 5 minutes. Okay, and remaining topic will take in the next 2 to 3 days. Okay, so we start with another talk: cell-free fetal DNA based non-invasive prenatal testing for aneuploidy. Again, here they can ask you a very small SBAs from this particular topic. What is the difference between NIPT and NIPD? Okay, NIPT is non-invasive prenatal test, while NIPD is non-invasive prenatal diagnosis. Okay, so this prenatal testing is a screening test. Prenatal diagnosis is a direct diagnostic test. When we do the prenatal NIPT, that means prenatal testing, non-invasive prenatal testing, we need to confirm it by another invasive test. While in NIPT, you don't have to confirm. That is what is the difference between the NIPT and NIPT. Okay, in both cases, we use cfDNA. Okay, that is cell-free fetal DNA we are using. Okay, so NIPT uses cell-free fetal DNA to test for aneuploidy as opposed to non-invasive prenatal diagnosis, which uses cfDNA for diagnosing the fetal sex, RHD status, and monogenic disorders. This was a EMQ which was asked, I think, in September 2021, most probably. So, if it is done for the fetal sex, then it becomes the non-invasive prenatal diagnosis and not the NIPT. Okay, so NIPT is a screening test and needs confirmatory invasive testing in cases of high risk or the positive result. Okay. NIPT demonstrate high sensitivities and specificities according to our recent meta-analysis, although it is less accurate for trisomy 18, 13, monosomy X, and 6 chromosomal aneuploidies than for trisomy 21. So what does this talk says? It is highly sensitive for trisomy 21, then it is trisomy 18, then it is trisomy 13, monosomy X and all. So this particular sequence you should remember, it is highly sensitive for trisomy 21 and less sensitive for other trisomies. Okay. Now, what is the basis for this NIPT? Okay, it is a cell-free fetal DNA which comprises small fragments of fetal DNA thought to originate from the trophoblast. These fragments circulate in the maternal plasma and form approximately 10% of the DNA fragments in the maternal plasma. Okay, so whatever the DNA is present in the maternal plasma, out of that 10% will be this coming from the trophoblast. That is called a cell-free fetal DNA. It is present in reliably measurable levels for aneuploidy screening from 10th weeks of gestation. These are all SBA. How much is the cfDNA contribution to the total DNA? It is 10%. At what weeks of gestation this is possible to detect? At around 10 weeks of gestation. And most important, it is clear quickly from the maternal circulation hours after delivery, making it specific to that pregnancy. Okay. Now, what is the test accuracy? NIPT for trisomy 21 and trisomy 18 demonstrated high sensitivity and specificity. Results for trisomy 13 reveal lower sensitivity. Exact reason for this is not clear, but generally it is because the low guanine and cytosine content known to exist in the chromosome 13. Okay, so trisomy 13 has got low guanine and cytosine content. That could be the reason. That is why it is less sensitive as compared to the trisomy 21 and 18. Okay, monosomy X also demonstrated reduced sensitivity compared to trisomy 21. So this is the chart. If you look at this particular chart, you will understand. See, look at trisomy 21. These were the studies and higher sensitivity to the extent of 99.4% for trisomy 21 and good sensitivity 97.7. So almost equal sensitivity for trisomy 21 and 18. But if you look at 13, it is only 90% and monosomy X 92.9. So it is less sensitive. Okay. Now, this is possible in the singleton pregnancies, but if you have a multiple pregnancy, then there are issues. Okay. Now, trisomy 21 was detected at a rate of 93.7%. So for singleton, they have mentioned it is 99.4, but for a multiple pregnancy, the sensitivity is 93.7% with a false positive of 0.23% in a twin pregnancies. Okay, demonstrating lower sensitivity than the singleton pregnancy. And what does the RCOG or ACOG says for these twins? That we will see in the subsequent slide. Now, in twins, we have two. One, it can be dizygotic twin or it can be monozygotic twin. When we have a dizygotic twins, that means the genetic material is different for the dizygotic twins. Now, suppose if the one of the fetus is aneuploidy or there is an aneuploidy discordance in the dizygotic twin, what is going to happen? One twin will have a normal genetic composition, another twin will have a aneuploidy. In that particular case, there is a discordance, aneuploidy discordance. Okay, and what happens? In this particular case, the affected fetus may have a cfDNA fraction below the threshold of 4% required for the testing. So minimum 4% should be fraction should be contributed from the affected fetus for the detection. Okay, while the unaffected fetus may contribute a high cfDNA. So one fetus is having aneuploidy and it is contributing less than 4%, while the other fetus is contributing normally. In that particular case, the total fraction will be adequate for the testing and you will get a false negative result. Okay, so this can happen in the dizygotic twins. Okay, and this is because of the unequal contribution by the affected fetus or the less contribution by the affected fetus. Okay, so testing in monozygotic twins, theoretically it will be easy because monozygotic twins will have a same genetic composition. Okay, so they produce identical DNA molecules, but one should be very certain that it is a monozygotic twins only. So we should be very sure about the chorionicity. Okay, another problem is that the single twin demise, as the effect of the as the effect that the cfDNA from the remised twin has on the NIPT test is not known. So if there is a one twin which has demised, in that particular case, how it will affect the NIPT result, that we do not know. Okay, because of this, professional bodies do not currently recommend NIPT for aneuploidy in twin pregnancies, including RCOG and ACOG. Okay. Then NIPT in twins, the same what we have discussed. Dizygotic twins, discordant aneuploidy risk is there. Unequal cfDNA may cause false negative. Then monozygotic twins, easier as DNA is identical, but chorionicity must be confirmed. In single twin demise, unknown impact on the NIPT results, and current guidance, RCOG and ACOG do not recommend NIPT for aneuploidy in twins. Okay. Now, what are the benefits of NIPT? First thing, it is a non-invasive test and it does not pose the risk of CVS, amniocentesis such as pain, small risk of infection, procedure-related miscarriage associated with CVS and amniocentesis. These are not there. Second, cfDNA is clear quickly from the maternal circulation, so it becomes very specific to that pregnancy. And third, the test has got a quick processing time. The processing time is 3 to 5 working days, same as your QFPCR, that is qualitative fluorescence polymerase chain reaction testing for invasive sample. So processing time is very quick. Now, what are the disadvantages of NIPT? The test is not 100% accurate. Okay, there are false negatives and false positive results. And occasionally the test will not produce the result, that you will get an inconclusive result. And the chance of this inconclusive result is around 2, that is 1.9 to 6.4% sample. Who have got unconclusive result are more likely to have the chromosomal aberrations. Okay, so the chance of inconclusive result is also there, and those who have there is a higher chance of chromosomal aberration in these patients. So you cannot neglect these inconclusive samples. Okay, so common reasons for the false negative and inconclusive results is, one is a low fetal DNA fraction in the blood sample, which is measured by specific markers of fetal DNA or algorithms applied to the sequencing data. And second is a vanishing twin that has disappeared prior to the woman's dating ultrasound scan, which if non-identical may cause false positive result. Okay, so these are the certain disadvantages of the NIPT. Sometimes there can be confined placental mosaicism, whereby the fetus and the placenta have two different lineages. As the fetal DNA fragments originate from the placenta, NIPT is unable to distinguish between the two. What happens? There is a placental mosaicism. The placental line and the fetal line, they are separate, and you may detect something from the placenta, but the fetal DNA fragment may be different. Okay, NIPT can detect maternal cancers and maternal copy number variants, which result in false positives and have ethical implications also. NIPT has an effect on fetal medicine specialist. With introduction of NIPT invasive test, they are decreased by 53% for amniocentesis and CVS reduced by 77%. That is what is the reduction in the number of tests. So this finishes the short talk article. In this talk article, you just have to remember the sensitivity of each. That is this is trisomy 21, 99%, 13, 97%, and sorry, 18, 97%, 13 is 90%, monosomy X is 92%. Then minimum cfDNA fraction should be, threshold is 4%, at least 4% cfDNA should be there for the testing. And second thing is that you have to remember this when it is present from 10 week onwards. So these are the things which you should remember from this particular talk. So I will stop here, and next time what I will be covering about the MVA, manual vacuum aspiration, then cesarean scar pregnancy I will be talking, then I'll be talking about abdominal pregnancy also. So there are certain TOGs which are remaining, and that I will finish in the next time.